Hi, everyone. Welcome to LDI's seminar on reforming primary care for a 21st century healthcare system. I am Rachel Werner. I am the Executive Director of the Leonard Davis Institute of Health Economics at Penn. High-quality primary care is the foundation of a high-functioning health system, and most evidence suggests that primary care is the only medical specialty where a greater supply produces improvements in population health, longer lives, and a greater health equity at a lower cost. Yet primary care as a foundation for our healthcare system seems weak and under-resourced. Primary care accounts for 35% of healthcare visits, but receives only about 5% of healthcare spending. And the outlook for primary care sometimes looks grim. Visits to primary care clinicians have been declining. The workforce is shrinking as clinicians often opt to specialize in more lucrative healthcare fields. And the COVID-19 pandemic amplified many of the shortcomings of our primary care system, particularly related to unequal and inequitable access to high quality primary care, and also our over-reliance on a fee-for-service system, which has pushed many practices to the brink of insolvency during the pandemic. While there is widespread agreement that we must expand and improve primary care in the US in order to achieve better health outcomes at a lower cost, we have a long way to go in making this a reality. We have with us today an amazing panel of experts to talk about how we get from where we are today to a more accessible, well-functioning, and well-resourced and equitable primary care system. And so we have a lot to talk about. And without further ado, we'll get started. I'm going to start by introducing our panelists. We have joining us today Patrick Conway, who is the CEO of Optum Care Solutions, where he leads a platform of innovative and value-based healthcare delivery offerings across the continuum of care. Prior to his work at Optum, he was CEO and president of Blue Cross Blue Shield of North Carolina, and prior to that was the director of the Center for Medicare and Medicaid Innovation. Ashani Ganguly is assistant professor of medicine and primary care physician at the Harvard Medical School and the Brigham and Women's Hospital. Her research focuses on the value of ambulatory care, the consequences of low-value care, and policies related to payment and delivery that affect patient outcomes and spending. Linda McCauley is the dean of the Nell Hodgson Woodruff School of Nursing at Emory University. She served as co-chair of the National Academy of Sciences, Engineering, and Medicine's Committee on Implementing a High-Quality Primary Care System, which produced an important report in 2021 on the ways in which a high-quality primary care system can be implemented. Jay Wando Olaiwola is a senior vice president and inaugural chief health equity officer at Humana. Prior to that, she served as chair and professor of the Department of Family Medicine and Community Medicine, and the founding director of the Center for Primary Care Innovation and Transformation at the Ohio State University Medical School. And then finally, we have Ellen Marie Whalen, who is the chief population health officer at the Center for Medicaid and CHIP Services, and a senior advisor for the Center of Medicare and Medicaid Innovation, where she works to develop, implement, and test innovative models of payment and service delivery, strengthening primary care and population health. Thank you all for joining us today. It's such a great panel to have with us today to talk about this important issue. Linda, I wanted to start with you, if that's okay. So as I said, you were co-chair of the National Academy's Committee on Implementing High-Quality Primary Care. And the committee tackled longstanding problems in both the delivery and the resources that we devote to primary care, as well as the way we pay for it. Could you start us out by just telling us what the Academy's recommended in terms of where to go from here and how to get to a high-quality primary care system? You're muted, though.
Thank you, Rachel. And your introductory comments were spot on the value of primary care. And it's really quite amazing that primary care is really the only part of the healthcare system in the United States that's been documented to result in longer lives and more health equity. But we have quite a challenge to demonstrate its value to most of the citizens in the United States. You also said that primary care is 35% of the volume, but only 5% of the cost of healthcare. Well, contrast that to specialty care, which is also about 35% of the volume, but the cost is 17%. not 5%. We need studies to really differentiate what the difference is in primary care and specialty care, and how we can drive more specialty care or the management of chronic diseases into primary care. So the committee took a very broad look at what are the major challenges that we have. We know the importance of primary care, but what has stood in our way in implementing improvements in the United States? And our recommendations are in major categories. The first are the need to have better payment models. And hopefully the committee will do some deep dive into payment models that could really accentuate and help us achieve the outcomes that we know that primary care can give us. Second, access to care. We have some really good models of primary care in the United States. They're just not accessible to enough people. And they don't always involve consumers or patients where they live and work. And the committee really found that the strong models of primary care are embedded in communities, and that interface between primary care and public health is critically important. And then the workforce, which is where I spend a lot of my time with looking at who's preparing the primary care workforce for the future. And it needs great attention. Something has happened that students today, trainees today are not incentivized to go into primary care, and we need to really work on this. And then to restructure our education so students and trainees can see these models of care embedded in communities and interprofessional delivery of care. The committee spent a lot of time looking at beyond physicians and nurses and PAs, nurse practitioners. We looked at other members of the care team that are so critically important: social workers and behavioral health and dentistry and physical therapy and pharmacists, so many that our students do not see these models of interprofessional care delivery. And then also, as you mentioned, COVID has really shown us some of the strengths and the weaknesses of the resources that we have to work with. And telehealth has emerged as really one of the most transformative ways that we can address improvements in primary care. So that's just a broad introduction to the approach that the committee took. So hopefully we can dive into some of these areas in more depth and further questions.
Yeah, those are all great great steps for implementing a better functioning primary care system. I hope to talk about all of them in the brief period of time we have together today. I'm gonna turn to you, Ellen Marie, for the next question. So in your role at Medicare, the Centers for Medicare and Medicaid Innovation, what was your response to each of the National Academy's recommendations? And I ask this because major changes in spending and payment would be required to implement the recommendations that the National Academy's made, and CMS obviously plays a very important role in those decisions. And so tell us a little bit about what your thinking is about how the challenges to implementing those recommendations.
Sure. Well, personally, I was thrilled to see the primary care document come out. Thank you to Dr. McCauley and your colleagues. Whenever I talk about primary care, I have to make a nod to Dr. Barbara Starfield, who I did my postdoc with, who I felt like was the grandmother of primary care. And so was thrilled to see the recommendations come out. But beyond just me, I will say that when these recommendations came out, we had great briefings from the National Academies, and the Secretary's Office then created, out of the Office of the Assistant Secretary for Health, an initiative to strengthen primary care, where we're looking at all the recommendations. And we're now in the process of doing an inventory to see what we're doing to specifically address the recommendations, but also a bit broader, looking at the overall goals. Are there other things that we're doing that we can be supporting the goals of the plan that came out? And it's been really fascinating to see folks come together. There's such a passion across all of HHS, And we realize if we pull ourselves together, we can make much different headways. And I will say that, CMS as a payer, we're obviously looking mostly at what we can do in the payer space. But I'm at CMS Medicaid, and we are acutely aware of the access issues. And so stay tuned, but we're going to be doing a lot more on access to try to better understand where our barriers are and what we can be doing there. I also remind folks that Medicaid is not just an insurer. We think of Medicaid as a medical assistance program. And so because of that, Medicaid as a payer will cover more broadly things that some other payers wouldn't pay. For example, there's a requirement to pay for non-emergency transportation. There's also the options that state has, all sorts of options to be able to look at some housing issues, some food issues. So the focus on equity is something that we at CMS, we at HHS, we in the entire federal government are paying such close attention to, and we're looking to see which things we have in our toolkit that we can promoting that. And we really believe that looking at primary care, looking at value-based care is a way to improve equity, looking at disparities, and also incorporating the social determinants of health there. So there's lots more I'm looking forward to saying, but we'll look to have that be part of the conversation that we have.
Thank you. Patrick, I want to turn to you next. You have worn multiple hats over the course of your career, but in most of those positions, I've thought a lot about the role of value-based payment and alternative payment models and trying to reform the way that we deliver care. Can you tell us a little bit about your thoughts about value-based payment, both from a commercial perspective and from the federal government perspective, and how far is that going to get us?
Yeah, so I'll do sort of federal, which we may talk more about, and then sort of commercial. On the federal side, when we were there, in the core fee for service, we actually made a bunch of small changes that we actually calculated this when I was there, shifted billions of dollars into primary care. The way the physician fee schedule works, it did shift money out of specialty care towards primary care. So in sort of core fee for service, CMI and sort of alternative payment models, which talk more about, we tried to make investments there into primary care. And the question is, were they sufficient? In the commercial market in Blue Cross North Carolina, we made major investments in primary care, which they actually has been published now, had total cost of care savings and quality and experience improvements. And my current role, where we have doctors, physicians, primary care clinicians across America, we incentivize them completely different. So we flip the model. Their model has no fee-for-service incentive typically, and it's all around total cost of care, quality, and experience, because we're taking full risk from payers across the country, and that allows us to flip the model of how we pay for primary care.
And so in your current role, you do a lot more with healthcare delivery than when you're working, for example, at Blue Cross Blue Shield. What kind of delivery innovations are necessary to make this successful and a reformed primary care system?
Yeah, the two that we're really excited about, so we obviously have clinics all across America that we want to function better. I'd say the two things we're wrapping around those clinics that I'm super excited about is home and community care. So we will send nurses, advanced practice clinicians, and others into the home for Medicare Advantage dual eligibles for very sick people, 9, 10 times a year. Real example, person was hospitalized 14 times a year, went to 0. And you just can't do that in a clinic environment. No matter how good a doctor you are in the clinic, that's not possible to get into somebody's home with that level of care. The other is mental and behavioral, which we can talk more about, where we're wrapping mental and behavioral care and services around primary care because they can't do everything. And that integration of mental and behavioral and feeding that data and information back to the primary care doctor or clinician, it doesn't have to be a doctor, nurse, clinician, et cetera, the care team. Those are two of the areas we're very excited about.
Okay. Great, thanks. So Wanda, I think that leads me to want to ask you a little bit about your view of primary care, and specifically, as we said at the top of this, there are well-documented inequities in primary care and access to primary care delivery. In your current role at Humana, you're doing work to try and think about how to best address those inequities. Tell us a little bit about what is the role of payment and commercial payers in addressing inequities in primary care.
Yeah, thank you. So I think there are a few places where payers can be really influential and impactful in expanding the ability for populations that have been made vulnerable to be effectively served by primary care and receive access to highest quality primary care that has a health equity focus. A few things that I can share is, thinking about how, and this is already said by my colleagues, but the ability of the payer to really integrate a view into social needs and health-related social needs into payment models, and being really thoughtful in the way you actually pay for some of those social challenges that people have and addressing them. So we're doing things like we have 3 major focus areas for some of our social needs work in the primary care setting, but also into our non-primary care membership, which is around food insecurity, social isolation, and transportation access. And being able to integrate payment for like healthy food cards, housing support, transportation access is a very important lane that payers can be in, and connecting our work to kind of a focus on the mitigation of those health-related social needs. Another place that is really important and probably not thought about as much is the opportunity for payers given the landscape. So for Humana right now, we are really transforming from largely a health plan to a health and wellness company, and we are a large provider of primary care to seniors across the nation now, and I believe we have 190 something clinics now where we're doing that. So being both payer and provider gives us an opportunity to think about what are we paying for, but also what are we delivering, and refining those care models. Looking at the way that we can shift from the fee-for-service, as you described earlier, to really value-based care models. Those are actually, and as we are kind of moving a lot of our practices on that path to value, we're seeing, cost savings, improved access, and the ability to really be more creative in the way we pay for things. And then the other thing, which was already mentioned, is there's a lot of opportunity in innovation in the Medicaid space. So we're largely Medicare Advantage, but increasing footprint in Medicaid. And I like what Ellen Marie said earlier about we see Medicaid as a vehicle for opportunity, not just for paying, but also for tackling challenges. And we have the flexibility and the opportunity in Medicaid to really rethink the way we actually provide services. So I think the payers have the opportunity, again, in the way what you pay for and how you pay for it, how you redesign delivery as a result of that payment structure, and then having an opportunity to create and innovate. And then the last thing I'll throw out is just because of the footprint that many of the larger payers have across the country, that gives you access to a lot of different communities, and being able to really dig in deep into what is necessary from an access perspective, from a team-based care perspective at the community level is another really important lens for the payers. And so where you can actually look at, evidence-based, scalable solutions that tackle access challenges, that tackle quality challenges with community partners is another place that I think we have a lot of opportunity with payers.
Great, thanks. So one of the challenges that people sometimes talk about is bringing those community partners into the payment system and integrating them effectively into a primary care delivery system. Are there examples of that you can tell us about where it's really worked well, and maybe give us some insight into that?
I'm happy to share one. With our growing primary care footprint, that's largely delivery of holistic primary care to seniors and in many cases frail and vulnerable seniors. We've got our CenterWell clinics, which are increasingly growing across the nation, and looking at this, building this model of really comprehensive, high quality team-based care, working at the top of the license, as Linda said earlier, but making sure that we are delivering on all the different needs that people have, whether they're behavioral, pharmacy, physical, social. And in many of those CenterWell clinics, they are clinics where we have, a sizable volume of our membership, so people that are Humana members, but they're also many of the patients in those clinics are not Humana members. And so what that does is it allows us to be both, the deliverer, the people that are delivering that care, but for some members paying for the care, but not necessarily all the time. And so what happens with that is that if you've got the ability to both be in the space of paying, but also delivering, you can elevate the standard of care that's expected, because nobody wants to do anything where they say, well, I'm a primary care physician, so I know how frustrating it has been times where it's like, well, you got to do this if it's Humana, if the patient has Humana, and you got to do that if they've got this. And so being in a place where it's really payer agnostic, we just want to give really good care. I think that allows us to actually be a little bit more nimble in the way we do things. So that's an example of where I think, when you're in that position where you're not necessarily just the payer, you're actually the provider, you get a lot of opportunity and insight.
That's great. Thank you. Ashani, I want to bring you into this conversation. You are also a primary care physician, and you have been studying primary care physicians for a while now. Could you tell us a little bit about what you've observed in terms of primary care delivery recently?
Thank you so much. So, I think office visits have long been the traditional delivery mechanism for high functioning primary care. And what we're finding is that over the past 1 or 2 decades, we've had this steady decline in primary care office visit rates, as you alluded to earlier, Rachel. And this is across US populations, and it's been accelerated by the COVID pandemic. So studies by my group and others have been starting to understand a bit more about why, and the implications are both positive and negative. So first, we find evidence of declining access to primary care, which is of course a bad thing. Fewer people are reporting that they have a PCP to begin with, and this is especially true in marginalized populations. We're also finding, and this is due in part to primary care workforce shortages and maldistribution, which I know we'll talk more about. We also find increases in financial barriers, for example, rising out-of-pocket costs for office visits, particularly ones that are problem-based. We see evidence of changing practice, and this is some good news, although we have to think about how it affects burnout for clinicians. So patients who do have PCPs are seeing them less often, but in tandem, these office visits are becoming longer and more comprehensive. So more diagnoses discussed, more orders placed, and PCPs are scheduling fewer follow-up visits and fewer visits for indications like lab results or low acuity problems, where really they could be dealt with in the course of fewer visits potentially. Patients and PCPs are communicating more and more by secure email. I'm sure you all have had this experience, whether as a clinician or a patient. And of course, virtual phone and video visits have rapidly replaced many office visits that happened early in the pandemic. And we see a lower steady state of that happening now with virtual visits. I'll also share that to a small extent, this decline is representing shifts to other settings, right? So going to urgent care, retail clinics, commercial telemedicine. And we also find a rise in specialist visit rates, as we've talked about a little bit earlier, and this is especially true in the Medicare population, in tandem with a growing supply of specialists relative to primary care clinicians. These trends probably represent a mix, like, as I mentioned, of good and bad news, and specifically what I'm hoping we can talk more about is how these can sustain our efforts to, affect our efforts to sustain primary care core functions. And this is going back to the Barbara Starfield concept of first contact access, interpersonal continuity, having a doc you know well and who knows you well, coordination across clinicians and settings, and comprehensive whole person care.
Great. So I do want to talk about the workforce issues, and maybe this is as good of a time as any to do it. And the issue of a declining workforce has come up a number of times by many of you have mentioned it, and also the tension between people choosing specialty care or primary care as physicians or other clinicians. And so the question is, what can we do about it? And I guess I'll start with a question of, we've talked a little bit about payment reform and using alternative payment models as a way to address some of the shortfalls in primary care. Is that going to, how do you think of that in terms of addressing workforce challenges that we currently face? That's to any of you. Patrick, go.
I'll start. I think it's probably necessary but not sufficient, and others can chime in. I'm not a workforce expert, but I think as you make investments in primary care clinicians and teams, I think it can become more, financially rewarding, in addition to all the other reasons people choose careers, intrinsically rewarding, et cetera, et cetera. And we are seeing that as we now have various employment or other relationships with over 60,000 physicians in the US, about 100,000, significant numbers of advanced practice clinicians. But when I say it's necessary but not sufficient, I think you also do other things that folks can talk about, training, loan repayment programs, the whole pipeline of various clinicians that go into these fields, and how do you address that issue? So maybe I'll let Linda or others talk about that.
So, Patrick, that's an important thought. The way that we conceptualize the training in primary care needs to change. And the committee, the National Academies Committee, really were not proponents of considering primary care as a specialty area. It shouldn't be one of multiple rotations. And that happens not only in physician training, but also in nursing educational programs. And we've got it all wrong, because they see it, they're out in the community, they see financially strapped settings, they don't see great models of interprofessional care. They never see the integration of home visits along with clinic care, Patrick, as you had described. And so the models that we educate students in would never incentivize a student to go into that field. Now, they're fantastic models, don't get me wrong, there's just not enough of them. Most primary care takes place in solo practices or practices connected with healthcare settings. These clinicians are overworked, under-resourced, limited space. The concept of they're taking a team of students to show them how an interdisciplinary team works, they don't have space to do that. And so we don't even have enough of the milieu, the positive milieus, to expose students that this is a care model that is exciting, that's community engaged, it's centered on families and multiple professionals working together. They don't see enough of it. And instead, it's treated as just one more specialty rotation. And so we got it wrong, completely wrong, on the way that we educate from the very beginning.
How much of the problem is the imbalance in payment? So we talked earlier about how little payment is going to primary care compared to specialty care, despite the fact that it's a large portion of office visits. Do we need to rebalance payments to primary care practices versus specialty practices?
Could I maybe share thoughts here, because I appreciate Linda's comments. I'm thinking, when I think about payment at the point of being already a practicing primary care physician or clinician, it's probably too late, right? Because I think what Linda's saying is that we're talking about before those decisions are made. What are the things that drive interest in going into any of the primary cares and specialties, and what are the things that kind of pique curiosity of a student to pursue that direction? And so I'm not sure that I think that's another question. That's an important question to think about, and that we should talk about that at some point, is what does that ultimately look like downstream? But I think further up, it's really like what are people seeing when they are seeing the primary care specialties, and what do they feel like their opportunity will be to grow and innovate and create and do good work in those areas well before they're at the point where they're getting a paycheck from it. So that's really, I think I agree with you, Linda, wholeheartedly, that the way, people make those decisions, there's pretty good evidence around that people make those decisions around, their ultimate field of practice pretty early on in medical school or other, training programs. And so whatever we're talking about really needs to be kind of much further upstream.
I would just add to that I think that how much we pay primary care doctors is a reflection of how much we value the profession, right? So I think that's something, that message comes across very early to students. I help to teach the health policy course for first years at HMS. And we've had this active discussion about how do we frame primary care and the role it plays, because the students are getting, so much more, in terms of the volume of, or the share of all of their lectures and their exposures is to specialty care. And so they see that as being more valued. And I would also say more broadly that we have an image problem in primary care, right? The public also sees specialty care as being more specialized and better. And that if you have a knee ache, you have to see an orthopedist. There's this sort of prevailing narrative that specialty care is higher value. And so I think that that translates also to what students come in with and what they are exposed to when they're in school.
I'll just add kind of, I really appreciate the point that we're late in the game at CMS when we pay for it. We need to have the group of folks there. And Linda, I really appreciated the focus on the team of care. That's one of the things that I think COVID has really highlighted, is that there is just such a dramatic workforce issue. And part of what we did during COVID was look to see if we had any policies in place that were standing in the way of using the entire team to be able to address primary care. And I think if we maximize everyone's contribution, it makes that primary care provider less responsible as an individual and being able to rely on entire teams. So for example, before COVID, there was a requirement that nurse practitioners and PAs couldn't prescribe MAT, medication-assisted therapies. And there was 287 counties across the country that had no provider of MAT. And once we lifted that requirement, that we were able to reimburse that, they were able to go into some of those counties. And I'll also just note on kind of the equity side, we're really looking to see how states can take advantage of the options they have for things like community health workers, doulas. That's an option that state Medicaid agencies have, and we are looking to work with states to be able to maximize that too. So really bringing the whole team to there to try to alleviate burden on any single individual.
So there's lots of questions coming in from the audience, and if the audience members have questions, please feel free to put them in the Q&A box. We will try and get to them, though there's so many good things to talk about here. One of the things I wanted that this conversation prompts me to want to ask is about quality measurement. So the National Academies in their reports that we should pay for primary care teams to care for people, not doctors, to deliver services. And quality metrics and quality measurement in general has focused on the delivery of services. And so specialty care really excels at diagnostics and therapeutics, and those kinds of things are very easily measured and quantified. Fair territory for use of checklists, for documentation templates, and the types of things that we've come to rely on in quality measurement. I think that, primary care, on the other hand, is much more focused on relationships and ongoing and team-based work, and harder to measure. And so how do you think about that? Given this, how should we be thinking about the delivery of primary care and sort of the integration of primary care into alternative payment models where quality measurement is important so that we don't stint on care and we know that people are getting adequate care? Anybody want to jump in on that?
I could comment briefly that we could turn back to Barbara Starfield's core functions of primary care. So one sort of piece of low-hanging fruit is thinking about continuity and the ability of primary care practices to offer interpersonal continuity, both at an individual level and a team level or practice level, because we know that's linked to these better outcomes, and it's a useful proxy process measure to understand if we're doing our job.
Great. Patrick, did you want to jump in?
Sure. Yeah, a couple thoughts. I'll be interested in others. I mean, from back in my days in Chief Medical Officer CMS, where we led the quality measure work, we tried, sometimes successfully, sometimes not as successfully, to say, what are core measure sets? How do we focus on outcomes, experience? We had dimensions of care that Ellen Marie was part of, so she may comment more on. That was just said that one of the critical points is there's often not great measures of what patients would want, true sort of patient reported outcomes and sort of connection outcomes. So I just think it is still, unfortunately, a gap. I often use the example, I care mainly for complex kids who happen to get hospitalized. Normally they actually have a set of goals for their child that are fairly driven by that individual patient and family, and we rarely measure at that level. In our system, to be frank, because we focus on pretty small set of measures that are like hospitalizations per 1,000, CG caps, a set of quality measures in our system, in the STAR measurement system, because that's how we're measured. So I mean, it's a pretty set and relatively parsimonious set of measures. Do I think it measures everything in primary care? No. would I like it to evolve to more patient-centered, outcome-oriented measurement over time that really gets at goals of care and how we accomplish them? Yes, but we focus on the identified core measure sets that I'm sure others do in the system as well.
So I think the outcome measures may be different for different segments of the population. And when I look at primary care, I think some of the importance of everyone having a primary care provider and knowing where they get their care. And when they move to the new community, being able to have that hookup and know where they're going to get care, that's critically important. But there are stages in life when primary care may be delivered in a school setting, or with college students, it may be in student health. And so it's not always the same entity or look and feel as a person goes through different ages. And then recently there was a workshop with the National Academies on managing patients or persons with serious conditions in primary care. I think this is such a critical area that we are not addressing, because there's so many people with chronic diseases who are being shuffled from one specialist to another, and there's no incentive to take that person with multiple complex conditions and say, this primary care service can manage your health problems. They stay with their cardiologist, they stay with their endocrinologist, they stay with their pulmonologist. Versus, there's no incentive, the healthcare systems, to stop that and say, this person with a lot of palliative care issues can be handled in primary care. And so that recent workshop's got some excellent recommendations, and hopefully there'll be some more work in that area, because that is where patients tell us a lot of it is just not wanting to be shuffled from one provider to another, to have one entity that cares about them, knows where resources are in their community, and can make their life simpler at this kind of point of their disease trajectory.
Thank you.
I'll just quickly note that, of course, the movement from fee-for-service to value-based care, looking at outcomes, is the direction that we need to be going. And of course, we need to know what outcomes they are, right? What outcomes we're measuring. And just to build on what Patrick was saying, at Medicaid, we have a core set of a child core set as well as an adult core set that has always been voluntary for states to report on. And recent legislation will have all of the pediatric measures being mandatory reporting for states. The behavioral health measures are all mandatory reports, and measures there that we spend a lot of time working across external stakeholders to decide what should be in the child core set and the adult core set. But they include well child care, they include immunizations, postpartum visits, and behavioral health visits. And so trying to not only what are those outcomes, but also we're very committed to trying to make sure that they align across programs. And so what we're doing in Medicaid, we work with the Innovation Center so that they can build that into their models. We're working with Medicare and the MIPS model because we understand for clinicians, you don't want a different set of measures for depending on the payer. And this isn't easy work. We appreciate hearing from stakeholders as to the direction we should be going, but making sure that we have those outcomes that do measure primary care, I think is a critical next step as we move forward, trying to develop better primary care models.
Great. So I wondered if each of you could tell us so there's a lot of different primary care models out there. There's a lot of work on innovating in primary care delivery systems. There's some payment models being tested. I'd be interested in hearing what primary care delivery models you're most excited about and you think hold the most promise. I do want to call out one comment that's been appearing in the Q&A, which is to not forget about the nurses in these primary care teams. And so I'd also be interested in hearing how the primary care team fits into these, primary care delivery models of the future. So I don't know who wants to start with that question.
I'm happy to answer what I think you asked, which is around like what the broader role of team members, but also what we're excited about in terms of what's on the the horizon. I think one place that I'm really excited about, it's not new by any stretch of the imagination, but certainly just increasingly much more discussed, is really the area of these other folks who have tremendous connections to communities, like community health workers and doulas, and in the case of maternal child care, but specifically how do those folks serve as a really important bridge, not only to deeply understanding the needs of patients and the experiences that patients have, and having that cultural and linguistic congruence with them, and the competency and the humility to be able to care for them. I think that is there, but there's also emerging evidence on the financial benefit of having these folks involved, and what you can save by having people that are able to connect with people in these ways that we historically cannot, as the primary the core primary care team. So I really think as we're looking more and more into some of the challenges that we have with people who are disengaged from care, or having difficulty navigating very complicated labyrinths in our delivery system, not really understanding their composite of health challenges, but also like medications, things like that. That's a really important role that I think we should pay a lot more attention to, and really figure out how do we leverage those skill sets. So I'm excited about that, and we're doing a lot of work right now with leveraging community health workers to really reach out to some of our members who have been most kind of disenfranchised, but also have high needs, and seeing if that is a model that we could use that's really outside of the walls of any particular primary care delivery setting. I do want to comment on just quickly on the care team, and hope that our comments have not implied that we're speaking only about physicians. I think we've all been very much in our careers committed to this comprehensive, integrated care where everybody has a role, and specifically, we all have strengths and weaknesses and blind spots, and so I'm a big proponent of that comprehensive multidisciplinary care team where you've got the nursing, the pharmacy, the behavioral health, social worker, all the other folks that have this tremendous expertise that's important for the work of the patient. So I don't want anyone in the audience to take away that we were excluding anyone. Absolutely, I think we all agree that workforce is so important, and the diversity of that workforce is incredibly important.
Great, thank you.
I think it's a complex question about the role of nurses, because, and I do this in my day job, right? I think we've made incredible progress with the integration of nurse practitioners and PAs into primary care and acute care settings. But I want to talk a minute about bachelor's prepared nurses, that the large majority of them, when they graduate, go into very acute care settings. And one of the reasons they don't go into primary care is because they don't see models of professional nurses functioning at the top of their license. And this care is extremely complex in primary care. And if a student only sees a model in which they're a traffic controller to get patients in and out of the door, that's not going to attract that BSN prepared nurse to become part of that primary care workforce. So it's which comes first, the chicken or the egg. Our primary care practices have got to have a financial incentive to adopt new models and to educate the future workforce, because they tell us if we find a great model, they have no time, space, or resources to partner with us to educate students. We have no incentive for them to take multiple students. And they do it out of altruistic characteristics of primary care clinicians, but we need incentives, because we will never drive the workforce to primary care if they can't see positive models of primary care. So we have to tackle it in many different directions.
Yeah.
Go ahead, Ben.
Okay. Oh, I'm
Wonderful.
sorry. I'll go next then. Yeah, I mean, I talked a little about this earlier, but I'll build on it. So, across our Care Solutions platform today, in this last year, we served over 40 million people. Optum all in is about 140 million. What I'm excited about when we work with the team about, and this is through employed people, but also contracted partner, et cetera. We don't have to do everything ourselves, but we want to meet any person, their physical, mental, or social needs in their home, period. Then what that means in reality is we will do tens of thousands of visits today into people's homes. We did over 2 million last year at the advanced practice nurse level. We do also RN level, community health workers, et cetera. And then the work I alluded to that I'm very excited about, we call it all different things. We don't really care that much about branding, and we serve 9 out of 10 payers in the country, 9 out of 10 health systems in some way. But it's the comprehensive care where we say, let's give us the most sick, most complex patients, dual eligibles and Medicare Advantage, and we will care for them soup to nuts, take risk on that care, provide exceptional quality experience, et cetera. And that's like when I did a ride around with one of our, happened to be a physician in this case, but could have been an advanced practice clinician. And it's amazing. You walk into the home and on the quarterback point, they're like, doctor, like, I love you. Like, look, when I have a problem, I call you. Like, you changed my life. Like, and like, it's amazing. And, I was like, I want to quit my day job and just do this every day. Like, this is awesome. And actually, I really had that thought. I'm not quitting my day job, but I was like, this has got to be amazing. I want to be this doctor. So, that's where I get excited. And then the behavioral aspects, like, we have so much work to do in mental and behavioral. So I don't know how to solve it yet, but how do we get a truly accessible, high quality system that generates equity and the outcomes we want in the mental and behavioral space?
Shauna, you're up.
So I'd love to see a model where we can see primary care docs and clinicians have the flexibility to both in payment structure, but also in their workflows to care for patients when and how they need, right? So via in-person, video, phone, email, home-based care, without having to count each widget. And this would take the support, of course, of multidisciplinary teams. And I echo Wando's comments there. I think they're really important. As well as updated technology. We are really behind in technology in primary care and healthcare in general. We're still using faxes and beepers. There's a lot of things we can do to make make us more efficient in primary care and allow us to use that time and spend it with patients, which is what really we value and patients value. And I also think a model that would support this kind of approach would be one that moves away from fee-for-service towards lump sums for patients that are risk adjusted, but not for how sick somebody is or how much Medicare spending they're going to have in the hospital, but rather clinical attributes and social attributes that are really about how much ambulatory care they need or how much work primary care doctors do working with them, right? So things like a range of mental health conditions, thinking about social risk, thinking about even something like patient email volume, which is something we can measure, right? And that more generally rewards the time that's well spent by primary care clinicians.
That's great. So a question about the costs of care. So Medicare has often taken the stance that the development of new payment models need to be cost neutral at a minimum, or cost saving, hopefully. The National Academies took a slightly different approach. They don't make the rules, but they recommended that payers evaluate, disseminate payment models based on the ability of those models to promote high quality primary care, not on achieving short-term cost savings. How do we balance those things? And is it realistic to think that we're going to invest in primary care delivery systems that may not be cost saving?
Prep, I was supposed to do this one, so I'll start, but others can add in. So that's a great question. So, CMI as El Marie, we work together. I mean, it's in the statute, like it needs to be. It does say though, it can be cost neutral and quality improving, and you can scale or quality down. So that is actually a scalable model. Quality up, cost neutral. People often forget that per the statute. And a bunch of the models that have been called not working in some evaluations, including in journals, when you actually look at it, there's a small number that are clearly cost losing, a small number that are clearly cost winning. The vast majority, it's actually unclear statistically, just since we're talking to the scientific audience, but somehow that middle bucket gets categorized as losing. That's actually technically not true. And actually the primary care models are great examples where we made investments that were, it was not clear there were cost savings, quality and experience generally went up. Ellen Marie was there. I think we underinvested. I thought it at the time. I still think it. I think, a $35 PMPM or wherever it landed once we were done designing the model at the time, I thought it was too low. I still think it was too low. I think that's the primary challenge. I think you have to flip the model. Most payers, are you willing to lose for years of investing? I mean, the reality is, let's be honest, I'm a transparent person. Most employers and most payers don't want to lose money in an annual cycle. They'd at least like it to be cost neutral. Could you convince them you're going to have a slight dip, but then you're going to get the savings later on? Yes, I think you could have that conversation, especially in the commercial market with employees. I think that population is the most likely to say, I'm willing to pay more for exceptional experience, quality, et cetera. But even there, I think if you say more is a relative term, I think most payers and employers care a lot about the cost trajectory of healthcare. So I think we'd be kidding ourselves to think that. Now you could solve that, sorry, then I promise a little longer than I meant to be, but you could solve that different ways. You can invest in primary care and take dollars from somewhere else, right? Because they care about their total cost of care investment.
Anybody else want to weigh in on that? Ellen Marie?
Yeah, I'll just build on that. So, we're now at the Innovation Center, we're on our third primary care model, and we've learned from each of them. We started with kind of a comprehensive primary care. We then did a second one, and now we're doing primary care first, and we're looking to see what we can do in the future. And I think, as Patrick said, and that's especially important for Medicaid, that success has to be cost neutral with improved quality measures. One of the things that we're trying to do in Medicaid is also look to see what we can do to change care delivery, even regardless of the payment outcome, because we can't accept clinicians to just suddenly switch on a dime and provide a different care delivery model. And that has to be the point of a new payment model, right? The new payment model isn't just fee-for-service is bad, so anything else is good. The new care payment model has to support the care delivery model that we want. So for example, things in Medicaid like the health home, which pays extra dollars for extra care coordination. It's not a savings, it's an additional benefit. But in order to do that, you need to create a new care delivery model. So looking to figure out where we can have on-ramps so that folks don't just have to automatically be in this new payment model. That said, I'll also note that the Healthcare Payment Learning and Action Network, which is a network that CMS has kind of created with the private payers, and Patrick was involved in forming that, which was brilliant because we know CMS can't do this on our own, right? It has to be a multi-payer. And we've looked to the private sector to see if they will take on some of the commitments that we've made. And part of what they're doing now is looking for ways to support other models, other states that want to do this. They're looking to have multi-payer next steps. In December, we announced the State Transformation Collaborative, which is bringing these folks together to say, how can you all come together? How can you look at some outcomes that are consistent across what you're doing? Some are doing primary care, some might want to focus on behavioral health, and we're doing extra support to help that move forward. And so I think looking at all of those issues as a way to try to figure out how we can get to the cost savings. But the LAN is also measuring APMs across payers. And I will say, we were actually surprised to see they've been measuring for, I think, since 2016 now. The jump from 2018 to 2020 in Medicaid jumped from 23 to 35% of individuals in a alternative payment model. But what was surprising was it jumped from 8% to 14% in downside risk. And so as much as we think that that's a concern, we also hear folks saying, if I do have better control over the care delivery, I can look and maybe improve outcomes and then keep the savings, and they're willing to go into a downside risk model.
Okay. So we just have a few minutes left. I have a couple of wrap-up questions. We'll do these quickly. So first, I wondered if you could tell me what, if we were to hope that 10 years from now we will have achieved some of our goals in reforming primary care, and there's a lot of work to do if it's only going to be 10 years, but let's say we're optimistic. What's the most important first step that you want to see happen right away that would help us achieve those goals of reforming primary care. And so, Linda, maybe I'll start with you.
Well, what I'd like to see first, and it comes from the report, is more of accountability in the government. The number of people who had significant input and responsibility for primary care in the United States was uncentralized and uncoordinated. And that's why the committee felt like for implementation, it needs to be at the highest level of the Department of Health and Human Services to actually, there can be great creativity at the community level, state level, but the overarching message has to come from the highest level of the government, and we've not had that.
Great. Patrick, you unmuted?
I'll go with fee for service over time goes to 0, and risk adjusted population, including social risk, population-based payments to primary care goes to 100%.
I like the brevity.
Can I go? Because I Patrick said what I was thinking I was going to say. So, but he said it in a lot smarter way than I would have said it. I think that's fantastic, and I'll just add on to that really being able to define and measure what equity looks like, health equity looks like in primary care will be really important. And I think it will behoove us to get that right. So that's the only other thing I'll add to Patrick's comment, but I agree entirely with that.
So articulating the share of spending and that we want to allocate to primary care and being explicit about that, the way that Rhode Island and other states have done, I think that policy change may go a long way, and just sort of all of the other things that follow.
Okay. And Ellen Marie?
Well, I'll end with highlighting how Linda began, which I think it's highlighting the importance, and we have to acknowledge the importance from the payer level of primary care, and we have to identify that we will not get to improved outcomes without an investment in primary care. And to Patrick's point, we've now made a commitment end of last year, that 100% of Medicare fee-for-service beneficiaries will be in an accountable relationship by 2030. And the vast majority of Medicaid beneficiaries will be in that accountable relationship. And you'll see it, we didn't say in an APM, we didn't say away from fee-for-service. And so that leaves us some leeway to define what that accountable relationship is. And we are looking to see how that includes a focus on equity.
Okay, and one last round robin here. I think I got all of you on that first one. I want to take your temperature on like what you will consider success in 10 years. So if we've achieved, what do we have to achieve in 10 years to feel like we've been successful and at least making progress in reforming primary care? Maybe not fixing the system, but making progress in reforming primary care. So beyond the first step, what do we need to achieve in 10 years? Linda.
So I would say I'd like to see a transformation in terms of what communities and patients, how they value primary care, that it is the top choice for trainees and for practitioners, physicians to actually want to work in that model.
Great. Patrick, you're up next since you jumped in that last time.
Oh no, I haven't decided yet. Hopefully this isn't too indirect. Where I went was like a model that meets everybody's individual needs. Like, I love virtual care and I never want to see my doctor. I said this once in a primary care, people and yelled at me, so I'm probably gonna get yelled at again. But like, it's one of my criteria. I've never met my physician in person. I love that about him and our relationship. But some people want care in their home, or they've got these different complex needs, or they're a family with a child with multiple complex needs. And so we have to have a primary care system that we've invested in with interdisciplinary teams that meets all those diverse needs. And I know that's a huge ask, but I mean, I think that's at the core of what we need.
Well, I hope your doctor doesn't need to listen to your lungs anytime soon.
Sorry, I'm gonna get called out again.
That's shocking.
This is just a small ask, but I'd like to see a fundamental cultural shift in how we think about primary care and the role it plays for individuals and for the public. I think this is both for patients, but also within our health systems, where I think if we value it more, all of these other changes may follow.
Wanda, I think I went out of order there, but Wanda, you're up.
No problem. I'd love to see primary care really be the leader in dismantling structural racism and biases that show up in care. And, you know, on the heels of these two studies that have just been published recently about like what we document in the electronic health record that continues to reinforce very negative stereotypes and perhaps implicit and explicit biases, we could really be leaders in redefining what kind of safety and cultural humility and cultural competence actually looks like in healthcare. And so I think that'd be a great place for us to lead as those that are really kind of focused in on our own role in reducing, mitigating biases and kind of making a much better experience for people of all backgrounds.
Great, thank you. And Ellen Marie.
I'll just quickly add, so I told you what our goal was for 8 years, not 10 years, was to get everyone in these accountable relationships. But I think what I would love to see is that patients know they're in a good primary care practice. They can demand it, they can ask for it, they can identify when they're not, and have the public better understand why primary care, what good primary care can do, and why they are entitled to be in a good primary care relationship.
Great. Well, thank you. Those are inspiring visions of what primary care might look like in the future, and I really hope we get there. I appreciate all of you taking the time to spend an hour with me this afternoon and talk about this important issues. We have a lot of work to do, but you know, you've added a lot of important issues to the conversation, which I think will help move it forward. Thanks to the audience for joining us. If you are around next month, we are having a seminar on reducing opioid deaths after, there we go. Reducing opioid deaths. So that's March 4th from 12 to 1. Please join us if you're available. Thanks everyone for joining us today. Take care.